Today, we are going to talk about diffuse connective tissue diseases, a group of systemic disorders that are chronic, involve inflammation and degeneration, and share many overlapping features. These conditions often run a course of flare-ups and remissions. Their causes are unknown, but they are thought to be related to immune system abnormalities. Some of the most common disorders in this category include rheumatoid arthritis, systemic lupus erythematosus, Sjögren syndrome, scleroderma, polymyositis, polymyalgia rheumatica, and giant cell arteritis. We'll focus on rheumatoid arthritis, or RA. RA is an autoimmune disease that affects about 1 to 2% of the population worldwide. Women are 3 times more likely than men to develop it. Although it can occur at any age, the most common onset is between the 3rd and 6th decades of life, with incidence increasing after age 65. Risk factors include family history, environmental factors like diet and geography, nulliparity, and modifiable risks such as smoking and obesity. The cause of RA is not fully understood, but we know it involves a genetic predisposition and an autoimmune reaction in the synovial tissue. Inflammation in the synovium leads to breakdown of collagen, swelling, and overgrowth of synovial tissue. This produces pannus, which destroys cartilage and erodes bone, leading to loss of joint surfaces and motion. Muscles degenerate, tendons and ligaments lose elasticity, and contractile strength declines. RA's inflammation has also been linked to arteriosclerosis and may interfere with cholesterol metabolism. Nerve involvement can occur as well, with synovial inflammation compressing adjacent nerves, causing neuropathy, paresthesia, or even vasculitis, leading to nerve damage. Diagnosis is based on criteria developed by the American College of Rheumatology and the European League Against Rheumatism. These criteria use a scoring system based on the number of joints affected, blood tests like rheumatoid factor and anti-citrullonated peptide antibodies, inflammatory markers like ESR and CRP, and symptom duration longer than 6 weeks. A score of 6 or more confirms the diagnosis. Clinically, RA often begins with symmetric joint pain and morning stiffness lasting longer than an hour. As the disease progresses, patients may develop swelling, warmth, redness, and decreased function. The joints feel spongy or boggy on palpation, and fluid may be present. It usually starts in the small joints of the hands, wrists, and feet, then spreads to larger joints like knees, hips, shoulders, and even the cervical spine. Symptoms are usually bilateral and symmetric with an acute onset. Patients may guard painful joints by keeping them immobile, which can eventually lead to contractures and deformities. Classic hand deformities include ulnar deviation and swan neck deformities. Unlike osteoarthritis, which is associated with bony nodes like Hibberdens or Bouchard's, RA deformities are caused by inflammation, misalignment, and partial dislocation of the joints. RA is systemic, so it extends beyond the joints. Patients may experience fatigue, fever, weight loss, anemia, lymph node enlargement, and Raynaud's phenomenon. Rheumatoid nodules often appear over bony prominences. They are usually firm, movable, and non-tender, and can vary in size. Other extra-articular features include arteritis, neuropathy, pericarditis, splenomegaly, and Sjögren syndrome, which causes dry eyes and dry mucous membranes. Assessment includes a careful history and physical exam. Nurses look for rheumatoid nodules, stiffness, swelling, tenderness, and warmth in multiple joints. Patients are also assessed for systemic symptoms such as fatigue, weight loss, and sensory changes. Rheumatoid factor is often present, but is not diagnostic by itself, while anti-CCP antibodies are highly specific for RA. ESR and CRP are elevated in active disease and used to monitor progression. CBC may show anemia or elevated platelets. Screening for tuberculosis, hepatitis B, and hepatitis C is important before starting immunosuppressive drugs. Liver and kidney function tests are monitored routinely. Imaging such as X-ray, ultrasound, or MRI helps establish a baseline and track disease progression, since joint damage can occur within the first year. The goal of treatment is to decrease pain and swelling, achieve remission, prevent joint deformity, and preserve function. Early, aggressive treatment leads to better outcomes. First-line therapy includes disease-modifying anti-rheumatic drugs, or DMARDs. Methotrexate is the preferred agent, though leflunomide, sulfasalazine, or hydroxychloroquine are also used. Biologic DMARDs target inflammatory mediators like TNF, IL-1, and IL-6, and are reserved for patients who don't respond to traditional DMARDs. They are more expensive, but tend to work faster and delay joint damage more effectively. JAK inhibitors are a newer class that block cytokine production. Corticosteroids may be used short-term as bridging therapy, but their long-term risks limit use. NSAIDs and COX-2 inhibitors help with pain and inflammation but do not prevent progression. Nurses need to be aware of gastrointestinal and cardiovascular side effects. Opioids are avoided because of the risks of dependency. For patients with established RA, physical and occupational therapy are critical. Patients are taught how to pace themselves, simplify tasks, and protect joints. Range of motion and strengthening exercises help maintain mobility. Surgery may be considered when pain is unmanageable or independence is at risk. Options include synovectomy, tendon repair, joint fusion, or joint replacement. Corticosteroid injections can provide temporary relief for severely inflamed joints. Topical medications such as capsaicin or diclofenac gel can also help. The disease takes a toll on emotional health. Depression, anxiety, and sleep disturbance are common. Low-dose antidepressants may help, and referrals to counseling or support groups are often beneficial. Obesity complicates RA, worsening pain and limiting mobility. Corticosteroids can increase appetite and cause weight gain, so dietary counseling is important. Patients are encouraged to eat a balanced diet rich in protein, vitamins, and iron, while maintaining calorie control. From a nursing standpoint, common problems include pain, fatigue, sleep disturbance, altered mood, and limited mobility. Newly diagnosed patients need education to help them understand their disease, take medications safely, and adapt to lifestyle changes. Nurses also monitor for complications. Cardiovascular disease is the leading cause of death in RA, linked to inflammation and abnormal lipid metabolism. Medication side effects must be closely monitored with regular labs and assessments. Patient education is one of the most important nursing roles. Patients need to learn about their medications, potential side effects, and the importance of consistent monitoring. They also need guidance on using adaptive devices correctly and safely. Patients and families should be encouraged to ask questions and express concerns, especially younger patients who may be worried about childbearing, work, or family responsibilities. Some patients seek complementary therapies. Acupuncture appears to be safe and may help, though evidence for other alternative treatments is limited. Continuing care often involves home health services, especially for older adults or those with limited function who live alone. Home visits give nurses the chance to assess the patient's environment, spot safety issues, and identify barriers to medication adherence. For example, a patient with RA and diabetes may struggle to administer insulin due to joint deformities. Home care nurses can recommend adaptive equipment and make referrals to occupational or physical therapy as needed. They can also connect patients with support services like Meals on Wheels or local arthritis support groups. Frequent contact with the nurse provides opportunities to reinforce disease management skills, monitor physical and emotional status, and help patients stay adherent to treatment. Patients should always know the specific type of rheumatic disease they have, understand their treatment plan, and keep up with follow-up visits and health screenings. Rheumatoid arthritis is a chronic, systemic disease that requires long-term, coordinated care. Nurses are central to helping patients manage symptoms, monitor complications, and maintain quality of life through education, support, and advocacy.